So I'm Heather Gatney, and I'm the coordinator of the CVFS webinar series. Thank you for joining us today for our first webinar of the new year. Our host today is Emily Trelevin, Research Assistant Professor at the Survey Research Center at ISR. Emily is going to give an overview of CVFS measures of child health and some comparisons of child health indicators in the CVFS sample to the broader population of Nepal. There will be a Q&A session after the presentation. We ask that you remain muted until then. During the Q&A, you may unmute and ask your question, or you can submit a question at any time today using the chat feature. We'd also like to remind you that this webinar is being recorded. If you have any objections, you may disconnect at this point. A recording of the webinar and the slides will soon be available on the CVFS website. So all yours, Emily.
Thanks, Heather. And then just to confirm, you can see just my title slide, correct?
Good.
Okay, great. And then for everyone else, I have video minimized. So if you have a clarifying question, I am happy to take those during the presentation, but you'll just need to verbally interrupt me, or Heather, if you see questions in the chat, you can flag those for me if you don't mind.
Yeah, no problem.
Great. All right. Well, thanks, everyone. So as Heather said, I will be talking about our child health data collection and then presenting some summary data from the child health indicators that we have collected so far in the Chitwan Valley Family Study. Since many CVFS users do not have a background in public health, I wanted to start out by giving a brief overview of key child health indicators today. When we want to measure how healthy or unhealthy a population of children is, what is it that we want to measure? Next, I'll talk about the two previous child health data collections that have occurred within the CVFS, which were in 2016 and 2019. So I'll cover what data was collected and how it was collected. And then I'll give a brief update on an upcoming planned child health data collection. Finally, as I said, I'll present a summary of child health indicators and then compare our CVFS indicators to the broader Nepalese population using demographic and health survey data. All right. So child health is often conceptualized as the health of children under 5 years of age, since this is the period when the risk of mortality is highest, although there are still many program and interventions targeted towards school-age children and adolescents. And since 2000, there's been significant investment to address under 5 mortality and morbidity, particularly through the Millennium Development Goals and the follow-on SDGs, through investments by Foundation, targeting both prevention and prevention of illness and mortality and treatment. Because under 5 mortality is relatively low in Nepal and particularly low in the CVFS sample, we're really focused on morbidity and indicators of health and well-being here rather than infant or under 5 mortality. So this slide shows a framework for thinking through intervention points to address specifically pneumonia and diarrhea related morbidity and mortality. But I think it's a helpful guide for thinking holistically about proximal and distal points of intervention and of concern and measurement for child health. So starting at the top with the most distal determinants, we can think about disease exposure, air quality, access to clean water and sanitation. Undernutrition underlies about half of under 5 deaths globally and can put children at risk for disease and poor cognitive development and educational outcomes, while obviously vaccines prevent disease. And then when children do get sick, we want to be sure that they have access to high quality, appropriate treatment in a timely manner. And I'll now talk more about each indicators in each of these domains. So starting with birth outcomes, globally about 40% of the burden of under 5 mortality falls in the first 28 days of life, or the newborn period. So many health systems, NGOs, and other stakeholders are really focused on safe quality childbirth to give babies the healthiest start in life. So key birth outcomes of interest include whether a child was born at a health facility and or with a skilled birth attendant, typically defined as a doctor, nurse, or midwife. Obviously, children that are born with skilled birth attendants in health facilities are most likely to receive quality interventions if anything goes wrong. We're also interested in measuring birth weight and identifying children that are low, very low, or extremely low birth weight who might potentially need interventions and more support in the first weeks of life. Initiation and exclusivity of breastfeeding can be an early indicator of health and nutrition. And then finally, access to postnatal care, making sure that children, that babies do receive a checkup in the first few days of life to make sure that they are not at risk for any immediate illnesses. In terms of vaccination, I'll use the terms vaccination and immunization interchangeably. Typically, governments are interested in whether or not children received an immunization, and then if so, if that immunization was received in a timely manner according to the country's prescribed schedule. And most commonly, we look at BCG, which is an immunization for tuberculosis that's not offered in the US, but is offered in most lower and middle income countries. Also polio vaccine, a combined diphtheria, pertussis, tetanus vaccine that sometimes also includes Hib and hepatitis B, and then measles or measles, mumps, rubella combined vaccine. In terms of nutrition, most often programs will take children's height and weight measures, and using that information combined with their age in months and sex, they can estimate which children are chronically malnourished or stunted, and that's low height for age, which children are acutely malnourished or wasted, and that's low weight for height. We can also look at underweight, which is weight for age, and also flag children that are overweight or obese, which is typically measured using body mass index or BMI. More and more programs are interested in identifying children with anemia, and then also measuring dietary diversity and micronutrient supplementation. So going beyond more simplistic measures of undernutrition to try and understand areas of the diet that might be lacking that might contribute to poorer growth over time. And then finally, particularly in high mortality areas, we're really interested in examining infectious disease prevalence and incidence. So common illnesses in early childhood are diarrheal diseases. We're particularly concerned about fever, especially in malaria endemic areas. Chitwan technically is still considered a malaria endemic area, although my understanding is that there has not been a recorded case in over 30 years. Though there are certainly many other infectious diseases that are prevalent there, for which fever would be an important symptom. And then finally, we are also interested in assessing the prevalence of acute respiratory infections, particularly pneumonia, since that is an important cause of under 5 mortality and morbidity globally. So typically we measure these by asking survey respondents if a child has experienced diarrhea, fever, and or cough, cough particularly with fast breathing in a specified period preceding the survey. And then finally, for children that are recently ill, we can assess their healthcare utilization and potentially their treatment outcomes. So did they receive any treatment? If so, how soon after illness onset? Who provided the treatment, or where was it sought at a health facility by a qualified skilled provider? And then potentially what types of expenditures families had for treatment. So turning to the CVFS, CVFS first collected child health data in 2016. And for this section of my presentation, I wanted to thank Dirga Gamiri, Indra Chowdhury, and Sarah Bronner-Otto for providing some information about the data collection. So this first data collection was initiated by 3 co-PIs, Sarah Bronner-Otto at McGill, Emily Smith-Greenaway, who is currently at the University of Southern California, but was a postdoctoral fellow at U of M at the time, and then Yasha Vaidya, who was a doctoral student at Brown at the time. Dirga Gamiri also worked with them, and each of the co-PIs provided some funding from their university. ISCRN, our data collection partner in Chitwan, also contributed some funding for this data collection, and the team received IRB approval from U of M and the Nepal Health Research Council, which is the IRB for health research in Nepal. The fieldwork was started in summer of 2016, and then data collection took about 10 months from September 2016 to mid 2017. The interviewers for this data collection included ISCRN staff interviewers who participated in a training specific to this data collection. And they were joined by local trained nurses who took the anemia measures and assisted with taking anthropometric measures, which I'll describe more in a moment. And to prepare for this training, some staff from UNICEF Kathmandu led a 1-week training for the interviewers and nurses, particularly focused on the anthropometric and anemia measures. The instrument included existing CVFS questions, so standard questions about educational attainment and other basic socioeconomic indicators that we've used in prior surveys, as well as validated questions from other surveys where possible for new topic areas, particularly child health. So for example, they drew heavily from the Nepal demographic and health survey, since that had been conducted, I believe, 4 times prior to this data collection, and there was a validated questionnaire available in Nepalese. So the team piloted all new questions and then pre-tested the full instrument in non-CVFS neighborhoods within the Chitwan Valley. And as is typical with our CVFS data collections, they use SurveyTrack to manage the sample throughout the data collection. The sample for this data collection was children under age 18 years. They had to reside in a CVFS household in a CVFS neighborhood, but they could be a permanent or temporary resident of that household. So that means as long as they were registered in the CVFS household registry, they were eligible for inclusion. So it included, of course, children that were permanent residents of these households. Their parents are enrolled in CVFS. They were born in those households and grew up there. But it also included some more temporary visitors. So for example, if a set of grandparents are CVFS respondents and reside in a CVFS neighborhood, their adult daughter may come to visit for 3 months with her children who are not permanent residents of that household, but because they're staying for 3 months, they were registered in the household registry and then eligible for this data collection. And then, of course, children needed to have a mother or female guardian present to consent and participate in the study. And children who were living apart from their mother or female guardian were excluded, since there was no eligible adult to provide consent. So mothers provided written informed consent for their own participation in the interview. And then they provided written informed consent for their child to participate in the anthropometric data collection and in the anemia blood draw. And then children and adolescents ages 10 to 17 provided verbal assent for their own participation in the anthropometric and anemia data collections. So the team included a large variety of domains of child health in this survey. We have measures of vaccination, both did the child receive it and then the date, so we can assess status and timeliness. There are a number of birth outcomes in the survey, including birth weight and length, whether the child was delivered at a facility and the specific type of facility and attendant at birth. Also information about initiation and exclusivity of breastfeeding. There's also a module on recent illness, so illness within the 2 weeks preceding for diarrhea, fever, and cough. And then for those children, measures of their subsequent healthcare utilization. We also collected height, weight, and mid-upper arm circumference among all children following UNICEF protocols for the data collection. And then anemia, which was measured by hemoglobin concentration in the blood among children, that should say 5 to 17, ages 5 to 17, following the DHS and World Health Organization protocols for blood sample collection. The team used the HemoQ device, which is a medical device that measures hemoglobin, and it's used in many household survey data collections globally, including the demographic and health surveys, or DHS, and it's obtained by a trained nurse using a finger prick. This survey also included several other domains, parents' educational attainment, and some information on their marriage. They also asked about women's social group membership and women's work, as well as husband's work. The interview, I'll just run briefly through the data collection protocol. So once the study was introduced to a mother, interviewers obtained written informed consent for her participation. They then, using a computer-assisted interview, administered the survey to the mother. So that was the questions about parents' educational attainment, women's work. Mothers obviously provided information about their children's health. At the end of that part of the interview, we then obtained written informed consent for children's participation in the anthropometric, and then if they were of the correct age, anemia data collection. Then the anthropometric measures were taken for all eligible children in the household, and then the interview concluded with taking the hemoglobin measures for all eligible children. So I'll talk a little bit more in depth about the anthropometric measures. As I noted, we followed the UNICEF and Demographic and Health Survey protocols for collecting height, weight, and mid-upper arm circumference data using their standard equipment. So UNICEF Kathmandu actually loaned ISCRN equipment. So we were able to use the standard SICA scales that are used in this type of data collection globally. As well as the measuring box, which is pictured here on the right. This is for measuring children who are lying down, but then it can be placed upright to measure children's height, although we used a stadiometer, or basically the standing height scale that you might see at a doctor's office. And then we're able to follow standard protocols. So including if mom needed to hold an infant, that we could tear the scale for the mother's weight and then take the infant's weight that way. Typically children over 2 or 85 centimeters are measured standing up, whereas children under 2 or less than 85 centimeters are measured lying down. There are some standard corrections if a child of a certain age needs to be measured in the atypical way. And then we can also check all measures against a plausibility chart estimated by the WHO for each age and sex. So what is the minimum and maximum biologically plausible height and weight for a child of a specific age and months and sex? So there are a lot of challenges to obtaining high quality anthropometric data. As I noted, we did a week-long training with experts in obtaining this type of anthropometric data. But once you get out in the field, you find challenges like finding an appropriate location at respondents' homes to take measurements. Obviously, for both the scale and standing height, you need to be able to find a flat surface. So there is a smaller proportion of CVFS respondents who have unfinished floors. So we needed to find a flat area outside. These are actually photos from 2019 that I took. Unsurprisingly, there are quite a number of children who do not want to be measured, particularly by a stranger. So interviewers really need to have parents and other family members around help participate in the data collection to get children to stand in the correct way and long enough so the interviewers can actually take a measure. And then finally, occasionally, you might get an implausible measure and need to remeasure children. So we can check to see if our data are of reasonable quality, both by checking against a reference population. So in our case, we're lucky that Nepal conducts the Demographic and Health Survey regularly, and that provides a nice reference population for us to compare to. And then, of course, there are also ways that we can internally assess the validity of the measures. I should say measures, not sample. For example, stunting is generally low in infancy and then starts to increase with age, peaking around ages 2, 3, 4. So if we saw higher rates of stunting in infancy that decreased later in early childhood, that would be a flag that something was amiss. Wasting in an opposite way tends to be highest in infancy and then declines. And then rates of stunting, which measures chronic malnutrition, are always higher than rates of wasting, which is acute malnutrition, because stunting is measuring a chronic condition. It accumulates over time versus wasting is a short-term outcome. So looking at our sample in 2016, the team sampled 3,330 children, just under 1,000 kids under 5, a slightly smaller number of children of primary school age, and then just over 1,500 10 to 17-year-olds. We had slightly more boys than girls in the data set, which is what we would expect since there is a since 2008 has been a slight skewness in the sex ratio at birth among the CVFS sample and in Nepal more broadly. We then did a follow-up child health data collection in 2019 to 2020. So I led this with Dirga Gamire. I received funding from the POP Study Center here, and Dirga received a faculty pilot project grant from the Population Dynamics and Health program at U of M. And we obtained IRB approval from U of M and the NHRC in Nepal, similar to 2016. I was able to lead a 1-week training at ISCRN in January 2019, and then the team continued to pilot and pre-test our instrument into February. And then we had some delays with getting our NHRC IRB approval, so data collection did not start until June 2019. And luckily the team was able to wrap up in early March 2020, just before COVID hit. Again, our interviewers were ISCRN staff interviewers that were trained for this specific instrument. And again, they were joined by local trained nurses who assisted with the anthropometric data and then collected the anemia data. And these are some photos from our data collection. We can see the ISCRN interviewers practicing with each other how to measure height correctly, and then practicing taking the weight of a child of an ISCRN staff member. So in this data collection, our sample was really similar to the previous one. Again, we interviewed children 0 to 17 in CVFS households in CVFS neighborhoods where a mother or female guardian was present. We also included children that had been in the 2016 data collection that had moved out of CVFS neighborhoods, but were still living in Chitwan Valley. But we did, for budget reasons, need to exclude CVFS households outside of Chitwan Valley. Again, we, for IRB reasons, excluded children who were not living with a mother or a female guardian that could provide consent. This time, again, we collected anthropometric measures among all children, but we had a smaller budget and could only do anemia measures among children 5 to 7. And our strategy was to basically capture the capture anemia measures among children 5 and older that had aged into the sample since the previous data collection. Again, mothers provided written informed consent for themselves and their child's participation. And then children and adolescents 10 to 17 gave verbal assent. We had response rate information available for this. So we had a really high response rate among mothers, which is pretty typical of a CVFS data collection. We had 99.3% of eligible mothers agree to participate. There were about just over 300 mothers who were excluded because they were either in Nepal, outside Chitwan, in another country, or 20 could not be located. We had a slightly lower response rate among children for the anthropometric and anemia data. Just over 91% participated in those, and that response rate includes children. These were primarily children that essentially wouldn't cooperate with the data collection rather than those that refused outright. This time we included, again, vaccination and birth outcome information, as well as breastfeeding, and then, as I mentioned, anthropometrics and anemia. New in this survey was abstracting a lot of the vaccination information is typically reported from a child's health card. And in Nepal, the health card includes a height weight chart for the first 2 years of life. So for children with a card, we abstracted any recorded height weight measures from the first 2 years to be able to construct growth measures. Unfortunately, many children were either missing their cards or more commonly had just a handful or none of these height weight measures reported on their cards. So it's not a strategy we'll continue in the future. And then again, our anthropometric and anemia measures followed our DHS and WHO protocols. This time, the survey domains for other measures changed quite a bit. Again, we did measure parents' educational attainment, but we collected an index of durable goods to be able to compute a wealth index, and also collected information on household land use, ownership, and other housing characteristics, including water and sanitation. And then we collected a household remittance calendar. So information on anyone that had migrated out of the household, were they sending remittances, and if so, how much? And that was done at an annual level for, I believe, about 8 years preceding the survey. In this sample, we had around the same sample size, slightly larger, about 3,600 kids, 0 to 17. We see a slightly different distribution of age, again, just under 1,000 kids under 5. But in this sample, there were more 5 to 9-year-olds rather than fewer than children under 5, and then almost 1,600 adolescents, and a similar distribution by sex where we see a slight skewness towards boys. And then finally, we have a planned child health data collection that's funded, but unfortunately has been delayed due to COVID. So we are hopeful that we'll be able to begin that this calendar year. So I'm going to optimistically call this our 2022 child health data collection. Sarah Bronner-Otto at McGill and I are co-leading this along with Dirga Gamire. Sarah has received a 5-year grant from the Social Sciences and Humanities Research Council of Canada, or SSHRC. That is covering most of the data collection. I received a supplemental grant from the Population Study Center endowment funds at U of M that will allow us to collect some additional information among 6 to 10-year-olds, or sorry, 5 to 9-year-olds. And then we are in process of getting IRB approval from U of M, NHRC, and McGill. Looking at our survey domains for child health, again, we're collecting vaccination, birth outcome, breastfeeding information. We have added back in the information about illness prevalence and healthcare utilization. We're again collecting anthropometrics, but we are not collecting anemia this time, in part because of the great additional cost of the data collection. And then new this time is a module on child development for children under 5. And we'll collect that information using the Ages and Stages questionnaire, which is an early childhood development screening tool that is commonly used in the US and many other countries. We're also collecting information, again, about parents' educational attainment, household durable goods, and housing characteristics. And then as a part of her grant, Sarah has developed a very detailed module on women's work and work histories. And I will also take this opportunity to plug her webinar on February 9th, where she'll be talking in more detail about her development and use of women's work history calendars. So one of the questions I'm sure that everyone here is interested in is, how do I access this data? The 2016 data is currently in the archiving process with ICPSR. So that means that we are in the middle of verifying it for accuracy and then expect to deposit it with ICPSR by March. We will then move on to doing the same with our 2019 data. Part of that is preparing it for public release and making sure that we are sufficiently protecting our respondents' privacy. We expect to have that deposited with ICPSR by summer. And then once it's deposited with ICPSR, they take a variable amount of time to actually publicly post the data. So once it is available, it will be available on our CVFS page on the ICPSR repository, which I linked here. All of the child health data will be restricted use initially because it is information about minors, and there's quite a bit of information that's really hard to completely de-identify. So it is available to most users. You'll just need to register and formally request access. So I included the link to that process with ICPSR. It is relatively straightforward. All right, so I'll now turn to describing some of our sample and some of the outcomes. So comparing the overall age distribution across the 2016 and 2019 samples, they're pretty similar, but we might see some evidence of declining birth cohorts in 2019. I think that that'll be something interesting to watch. And then we have a panel sample of just under 2,500 kids. So these are children that were initially interviewed in 2016 and then re-interviewed in 2019. So the distribution by sex matches our two prior data collections, unsurprisingly. And then of course we can see the effect of aging 2 years on our age distribution. So as we expect, we see children have aged about 2.5 years, which is about the median time in between interviews. So I'll now present some key indicators from the 2016 data set. And most of these were collected among the full sample, so children ages 0 to 17. About 2/3 of our sample was delivered in a health facility, and so that includes a government hospital, primary health center, health post, or private clinic. Most babies that are not delivered at a health facility were delivered at home, primarily the respondent's own home, but for a small proportion in this group, someone else's home, likely their mother. We see that the odds of being delivered at a health facility decreases with age. For each additional year of age, children had about 0.78 times the odds of being born in a health facility. So younger children are increasingly born in health facilities. Surprisingly, only about 26% of our respondents reported that their child was delivered with a skilled birth attendant. Typically, we expect these two indicators to match much more closely. So we investigated this a bit further and found that the wording for this question did not match exactly how it was asked in DHS, and was framed more as who was present at a child's birth. So we expect that many women considered, since say their mother or another friend or relative was present for the entire duration of labor, that they may have reported that person instead of a doctor or nurse, despite delivering in a health facility. Turning to our nutrition indicators, we measured height and weight among children, all children ages 0 to 17, but following conventions, we don't estimate each nutritional indicator for all ages. So stunting or chronic undernutrition is measured among children of all ages, and just under 20% of the sample was stunted. Underweight is measured among children under 11, and so about 16% of our sample is underweight, which is an indicator of both chronic and acute malnutrition. And then acute malnutrition or wasting is only measured among children under 5, and just under 10% of our sample was acutely malnourished in 2016. As I mentioned, we measured anemia, which is highly prevalent across Southeast Asia, including in our sample. Almost half of 5 to 17-year-olds in the CVFS are anemic. It's more prevalent among girls, which is typical, and then we see a slight increase among adolescents compared to children 5 to 11. Breaking down undernutrition by age, we see that stunting is most common in ages 3 to 5. After age 5, some children do recover from stunting, which is why we see these lower rates among primary age children. And then we see a small increase in adolescents, and that's likely evidence of higher rates of stunting among these older birth cohorts. So I think that this is evidence that stunting has declined over time among the sample. As I noted, underweight is measured among children under 11, and we see a more even distribution by age, which is typical for this indicator, though it is usually lower in infants, and we see that in our sample as well. Looking at infectious disease prevalence, specifically diarrhea, febrile illness, and respiratory infections, among children of all ages, 3% had diarrhea, just under 15% had a recent fever, and about 1% had an acute respiratory infection in the 2 weeks preceding survey. And the majority of those with recent illness were children under 5, as we would expect. I broke that down for each of the symptom categories here. And then this graph shows healthcare utilization outcomes among children of all ages who were recently ill by disease type, so by fever, diarrhea, and acute respiratory infections. So we see that children were more likely to have been taken to a health facility for treatment if they had fever or acute respiratory infection, whereas parents were more likely to wait it out or treat at home for diarrhea. And then this treatment at home by a health worker was only reported as an outcome among children who had fever, which is why we don't see any respondents reporting that for diarrhea or acute respiratory infection. So both the CVFS and the Demographic and Health Survey, or DHS, collected data on key child health indicators in 2016. For those who are not familiar with the DHS, it's a set of harmonized, repeated cross-sectional household surveys that are conducted in many lower and middle income countries, including Nepal. And they aim to collect nationally representative population, fertility, reproductive, maternal, child, and other health indicators. So comparing CVFS to the DHS, allows us to see how our sample compares to the rest of Nepal. So in the next few slides, I'll show how child health indicators among our sample of children under 5 compare to the DHS sample. And I'm going to use our 2016 data since that was the most recent DHS and we collected data in that same year. For each outcome, the CVFS sample is approximately 940, but I did report the exact N on each slide. I pulled the DHS statistics from their website, which is called Stat Compiler, and it unfortunately only reports the weighted proportion. It does not report the N. So the 2016 DHS had about 4,800 kids under 5, so we can assume that the sample is about that for each of these indicators. So first, looking at birth outcomes among children under 5, we see much higher rates of facility delivery among the CVFS sample. Part of this is likely geography. So compared to many parts of Nepal, Chitwan is flat, and there are 2 highways providing reasonable access for many residents to the hospitals in Bharatpur and Narayangat, which are the urban area in the central part of the district. Versus in the Himalaya, many Nepalis have really limited access to health facilities. However, reports of having a skilled birth attendant are far lower in the CVFS sample, especially among those who reported a facility delivery, but we see that the rates of these 2 indicators are almost identical in the DHS sample. So as I noted before, this is the sort of relationship between these indicators that we would expect. So we suspect that this is due to our difference in wording. Overall, vaccination coverage in Nepal is really high relative to other lower and middle income countries. Vaccination is typically measured among 12 to 23 months old, since they would be past the point of the recommended time of receipt for each of these vaccines. So we had 204 infants, 204 children 12 to 23 months for whom we have vaccination information. About 71% of these children had a vaccine card. So for those children, vaccination information is taken from the card. The other 29% mothers reported based on recall. In the DHS, about 52% of these 12 to 23-month-olds had vaccine cards. So there's a much higher proportion of respondents in the DHS who are reporting information by recall here. But overall, we see extremely high, almost universal vaccination coverage in our CVFS sample, and this is really consistent with reports from the District Health Authority in Chitwan, and then lower vaccination receipts once we look nationally. Turning to undernutrition, we see almost identical rates of acute malnutrition or wasting among children under 5 when we compare the CVFS sample to the national sample. We have a slightly lower rate of stunting and then a much lower rate of underweight. Chitwan is a primarily agricultural area and food producing, so that may contribute to some of these lower rates of undernutrition. Turning to infectious disease prevalence, this is comparing just children under 5. So we'll see slightly different numbers from what I reported before. And then note that this axis only goes to 50%. We see similar rates of diarrhea, although our 2016 instrument defined diarrhea as 4 loose stools in 24 hours, while DHS defines it as 3. So there may be some slight differences in reporting due to that. We see a higher incidence of fever. I'm not sure why, though both data collections spanned about 8 to 10 months, so that should sort of cancel out any seasonality effects. And then similar rates of acute respiratory infection. And then we see really similar rates of healthcare utilization among recently ill children. So for children that had any of these symptoms within 2 weeks preceding the survey, this is the proportion that were taken to a health facility for treatment. So slightly higher rates of being taken to a health facility in CVFS for fever and ARI, but I'm not sure that these are significantly different. And I will end there. We can jump to Q&A. Thank you.
Emily, can I ask a quick question? This is you,
Sure.
Braz. Thank you. That was very nice and useful. We're also able to compare the obesity rate among children, CVFS versus DHS.
That is a great. Yeah, that's a great question. I have not done that personally, and I'm not sure that anyone else has, but we do have the data available to do it. So I think particularly among school-age kids and adolescents, that'll be really interesting to see. And I think that that's one of the things that I'll be interested in looking at once we have this 2022 data too, to see if we have an increase over time. And I'm not sure about what rates of obesity among children in Nepal are. So if you happen to know, or Dirga, if you know, I'd be curious. We can look it up on DHS later, but.
Yeah. I have no idea. No.
Yeah, me neither. But I would think that it's probably higher in Chitwan than the country as a whole.
Yeah, I would guess the same. So it'll be interesting to take a look at that.
I think I'm just thinking about this and trying, especially since we are still working on the questionnaire for the 2022 data collection. Like the kids, vaccination is a really common way of assessing how, the kind of connectedness of health and how healthy kids are and how concerned we should be. And these kids are all well vaccinated and they don't seem particularly, they have lower rates of many of these health outcomes. So I'm wondering if we can brainstorm more about this is kind of why I wanted to do this child development indicators, is like, how can we see how kids are doing with some other types of measures? But I'm wondering if there are other health measures, like physical health measures, that we should be thinking about for kids.
Yeah, I think that that's an important question. And some of the things that are on my mind that no one has looked at to date that I'm aware of. We've looked at receipt of vaccination, but not timeliness. And from what I understand from visiting the district health authority in Chitwan is that they tend to organize large clinic days. So I would assume that that's then going to drive some differences in the timeliness of vaccination. And that's a really important outcome because you're essentially delaying protection for infants when they're most vulnerable. So if you got your diphtheria, pertussis, tetanus 6 months late, that's an additional 6 months of risk that you're facing for those diseases. So I think looking into timeliness and how that varies by subgroup could be potentially important. I think looking at some more nuanced measures of nutrition. So 30% is a really high rate of stunting still, and South Asia has the highest burden of undernutrition globally, significantly higher than sub-Saharan Africa. So I think looking at things like receipt of micronutrient supplementation and particularly dietary diversity are going to be really important. The challenge is that collecting good data on dietary diversity is really intensive and challenging. So that is one of the reasons why we have not included it in our next data collection, but it's something I would love to get more information on in the future. And then I think looking at anemia in early childhood, which we have also not done yet, is potentially another important indicator. And then lastly, I will add, Sarah knows this, but we are adding a question asking parents broadly what they see as the most important child health problem. So I'm curious to see if that will potentially yield some valuable information for us, understanding, does our perception as health researchers sort of match what parents actually care about and perceive as important problems in their community?
Sarah and Emily, I wanted to ask you as a follow-up question, but that last prodding of what do parents think make me want to go with oppositional defiant disorder. I find child oppositional behavior to be the worst one for me, Emily. But I don't mean to speak for the parents. But anyway, look, and then maybe that speaks to the age question I was going to ask, because that kind of conveys that I'm a parent of teenagers. But I am curious, when you ask Sarah the question of what other child health questions should we be asking, how age specific the question itself is and what it means about over time. And I'm motivated to ask because Pam Jagger, who was with us in late December when we talked, Dirk and I just worked with her to submit this proposal where her child health measurement goals are lung function via a spirometer and blood pressure, which I've not heard Dirga, Emily, Sarah talk about before with regard to this data collection until all of a sudden, I mean, Pam's obviously very focused on air pollution, and that's why, but nonetheless curious how we decide by age what all to measure.
I mean, I will say historically, it's been driven by what does the global health community perceive as the most important health issues at certain ages. That's really the simplistic, but also the correct answer. And I think Pam's also measuring that in school age children, right? She's looking at 5 to 10-year-olds.
Dirga should correct me. I think it's more like 7 to 15. Is that right, Dirga?
Yeah, 8 to 15, right.
8 to 15. And yeah, part of the reason is because the individual level exposure to air pollution actually varies by where exactly they go to school and what they do during the course of the day. And new technologies allow us to measure that at the individual level. And so it's trying to separate that from what I guess historically air pollution folks have looked at, household level air pollution and community level air pollution. But this allows us to add a level of individual. So I know that that's part of the motive.
And I think,
But Pam also, Pam and that team was a bunch of sciences that I don't want to pretend I understand, clearly identified Chitwan as a good place to do this research because the air pollution is not the worst in the world, but bad enough to find these effects.
yeah, I think a lot of the history about what do we measure in global health is also so driven by cost and feasibility. So I think that as we have cheaper technologies to measure things like hemoglobin and lung function, and that becomes more feasible to do at scale in CVFS, it really opens up a lot of new possibilities for us, which is exciting. I think there's also been there's just such a focus on under 5s because of the higher mortality risk that we're really lacking globally a lot of information about kids that are in primary school age. And then you start to get a little bit more about adolescents, but I'm sure our adolescent health researchers on the call would argue that's also sorely lacking.
Well, and Dirga may not like me saying this, but I am dabbling in his new data on 8th grade, where his work with DFID education sponsorship was a really deep dive into 8th grade and attendance and test scores. And I think it does open for us dimensions of health that don't result in death. And I get it, like demographers have been obsessed with death, but at the same time, it seems like, not just impairing in the long term, but even changing people's life courses that somehow interfering with their ability to succeed in school might be health problem enough to have long-term consequences that we should be considering, not death.
Yeah, and I think that the nutrition really underscores that too. I mean, there's been just really fabulous high quality research showing that poor nutrition in early childhood basically impacts everything you can think of in later life, not just your mortality risk in early childhood. So, there's so much more nuance than just, are you short for your age? Are you thin for your age? That I think we have a lot more opportunity to capture that nuance going forward.
Oh, I really shouldn't go here, but I am dying to get some fMRIs in Chitwan. This work that SRO is implementing for Greg Duncan and his team called Baby's First Years, where they're finding that $300 supplement to poor people's incomes improves brain function of their babies, is really telling at how the social and economic environment does have these long-term consequences so it's via the physiological development of brains. Wow. Dear guy, I'm sorry you're not leaving for Nepal on Monday. I've been really bummed since you sent that message. But if you were, I'd say let's look for some fMRIs in Chitwan, because this would be cool to start doing that kind of work.
Yeah, and if others have suggestions about other health outcomes that you think are worth exploring, I am always happy to have that conversation. So please feel free to reach out.
Can I add one? I guess this is a question more than a comment. Are you also planning to collect data on healthcare expenditure?
Sarah, I don't think we have that in our survey. And Yuvraj, it's a great question. And I think we're pretty maxed out on our survey. You may have flagged this at a time where I'll probably bring it up for a discussion at our meeting tomorrow. We are planning to get more specific information on which facility people attended. So that's obviously not expenditures, but at least it does give us some more nuance in where people are seeking healthcare, so that we can get a bit more nuance on utilization. But I do think expenditures is a potentially important and interesting thing for us to examine.
Yeah, I was actually thinking more in terms of looking at the changes in household welfare as a result of child illnesses, for example. That's something like that we wouldn't be able to do with the existing data.
Mm-hmm.
So Emily, I'm sorry if I at one point it wouldn't be a good Zoom meeting if someone didn't drop out at one point, and that's what I did. So I might have missed a couple of these things. But yeah, I agree with some of the things that Bill was saying in terms of other additions. It sounds like you have a lot of those. I was thinking about lung function in some ways. And I mean, you did mention hemoglobin, which is a not hard thing to measure now, but one of the things we found is that in generally healthy populations, like the leverage ends up becoming in these behavioral measures, right? And that's where like you start to see enough variation to do anything. At least in the few studies that I've done on this, is those end up becoming the big ones. So maybe you discuss it. But the question I was going to ask was, could you talk a little bit about how easy or hard it is to merge with all of the other CVFS data?
Yes, I can, because I have quite a bit of personal experience with
Yes.
that. The merges themselves are pretty straightforward. Sorting out if you have merged to the correct mother and father, like doing it at the child level, is actually really straightforward. So for children, we can easily merge to the household registry. So that gives us a lot of information over a child's life course. And then we can also pretty easily merge to neighborhood, school, and health history calendars. Of course, with the caveat that we're using the child's current location and they could have changed locations, and I have not gotten into time varying location merges yet. Although in theory, that should also be relatively straightforward. Where it gets a little bit trickier is making sure that you have correctly matched the mother reported in the survey to the same individual interview from 2008, life history calendar, and registry information. And that is still, we think that we've done that with pretty high confidence. What actually the hardest part is sort of narrowing down the sample. If we want to look at what we might, I'll use this term, but I don't like it, true CVFS respondents. So basically, how do we knock out all of these kids that are visiting grandma and grandpa and were just here for 4 months and popped up in our data collection? That's actually the most challenging thing of all to do, because it involves going back through, basically at a monthly level, through the registry data, trying to figure out where a kid was born, how long have they been in CVFS for, and then making sure that we're retaining the right children and removing children that do not meet that definition.
Thanks. That's helpful.
When Folder was raising the behavioral part, I was my head was going like on childcare. Like childcare is changing rapidly. I would say rapidly changing. That means more children are going to formal childcare center. And I was wondering whether that has any interaction with their health. Yeah, finally, we would like to know about the learning, but yeah, and yeah, childhood, early childhood learning is another area which, yeah, none of us are really getting into that at this point, but that would be another interesting area within CVFS.
Yeah, even putting together some descriptives on which, on what proportion and which kids are accessing any sort of formalized childcare, daycare, enrichment programs prior to primary school. I know, Jerry, you've noted that anecdotally, but I think that that's something interesting that we could also compare to, particularly their nutritional outcomes.
We have 3 minutes left, but I have to run. So thank you, Emily. And are you going to make your slides available to some of us who may need this exact information in the future?
Yeah, no, I heard, I was thinking that too, like, that's a little bit different than the video recording of the session, Emily. That's looking some of us see your slides, yes.
Yes.
Thank you. All right, bye everybody.
Thanks, Sarah, see ya.
Yep.
Do any other folks have more questions?
Is like Elise our only remaining guest? Should it be like Elise, it's all yours now?
No, nothing. I mean,
You do
nothing to
not
add.
have to put you on the spot.
I went for it, you know.
Good,
I don't
nice
have
to
any
see you.
chance to put Elise on the spot. Yeah, very nice, Emily. Thank you for your
Yeah,
work on
thank
this.
you, Emily. That was
Yeah, thanks. It was helpful to
for
hear.
everything that I saw. It was great. If it was bad when I wasn't on, then I take it back. But
You actually missed the best parts. You
I
better
did.
watch the video, yeah.
Yeah. Okay.
All right, well, thanks so much, everyone. I appreciate you coming. And of course, if you have follow-up questions later, don't hesitate to reach out.
Thanks.
Thank you.
Bye.
Bye.